Hey, Mary. And I see hemodialysis is here. Did you on that? Or is it just all? Oh, no, it's Haley Dodson,
Really?
hemodialysis.
Sorry. I don't know why my Zoom always changes my name every time.
That's a
I,
great abbreviation, though.
yeah. I once was being snarky and I changed my name to something bratty. JD did it too, a while back. And then I had to change it so that it wasn't snarky that next meeting. And I changed it. I just like did like bland Zoom user. I think I was just trying to do it fast so that the snarkiness didn't get communicated. And so now it's set at Zoom user, which is fine. They just have to change my name each time I like log in. But there are a couple of Zoom accounts that don't let the audience change their name. So I always have to email those. I mean, I guess I could probably relog and create a whole new Zoom account, but don't be snarky at some point because then you'll have to change it to something bland. Also, Haley, I did send you an email back about that UC Davis case.
Yeah, I saw
Okay.
that. I saw it. Yeah.
Sorry it
Yeah.
took so long for me to get to it. It was, oh yeah, I forgot to answer this.
No, it's fine. It was a lot of information. So,
Yeah, if they can cut one more section, I think that they might have more information. I've had a few of them where they've just missed the papilla and they've missed like huge papillary necrosis. We
okay.
actually sent a final, you might have gotten that report. It was one of the Korean cases, I think. We did a consult on it, and the original pathologist didn't have the papilla, and then they had sent us the rest of the kidney because like they only took like a small part for their pathologist, like of cortex. It wasn't like a trimming issue, it was just that what they gave them. And they sent us the rest of the kidney, so we got the middle section of the papilla, and it was perfect for papillary necrosis.
Yeah, I let him know. So he hasn't responded yet, but
Yeah,
I'm sure
it's
I'm
been,
sure
it's
he'll be
been an
willing
hour.
to. Yeah, I'm sure he'll be willing to trim more. So,
But it is good knowledge for a pathologist to section a kidney right down midline. I think, and you probably are experiencing this as well, is like with our caseload changing a little bit and getting a few more renal tumors at the IVRPS, our group doesn't actually always remember to trim the tumor like the way a biopsy would be trimmed with compass points. And so they do specifically trim right down that center line on the medulla to
hmm
get the papilla. So I think that we just also need to be aware for IVRPS of like if we're looking for a tumor, like it's good to have that whole section so we know what the papilla looks like, but we need to make sure we're getting our compass points for our tumors and stuff. But that's just our caseload is kind of changing as time goes by. Hi, Dr. Hocamp. Must be sunny in Texas if you're wearing a tank top.
It's actually raining today.
Mhm.
Um, it's not a tank top.
Rainy
It's a
and
Oh,
cold.
is it a
jumpsuit.
dress?
It's a jumpsuit.
Oh.
What's
Oh yeah,
almost?
you like your jumpsuits. I'm not a fan.
You love a
I
jumpsuit.
mean, they
Oh,
look cute on you. I'm not saying they don't look cute on you. I'm just saying like, I'm not a fan of wearing
really
jumpsuits.
terrible. Oh no, computer is an idiot. Can you add? Can I add?
Yeah,
Hmm?
I can't. My now my computer is saying I have no
Oh,
camera that is connected, which is ironic
oh,
because it's integrated into the computer.
oh, yeah.
So also it's perfectly fine that nobody wants if no one wants to see my face. I can appreciate that.
I mean, I can
Um,
just put your picture that I now have when you text me, and that'll be the whole thing that's whenever you're talking. It'll just
Yeah,
that.
that sounds
To
great.
be clear, the
Yeah.
picture is her of her bowling, and I will say that I bowled a 12.
and
So
I
there's
probably
nothing
bowled
about
worse.
um
Uh,
okay,
But what did you want me to add, Jenna?
I didn't. Well, if this might be fine. Is it allowing? Um, can you see my thing?
I can see
you see
it.
the presentation. It's like the
Can
working mode. It's not presentation mode.
Yeah. Okay. Um,
Do you need us to like add your phone or something or
well, now I could just go to Pocamp's office, so I was thinking.
oh that's fine. Yeah, if you want to head over there. I'm not sure how far away you guys live from each other.
Or like really
down
close.
the hall.
Hmm.
Or like neighbors.
You're
Oh,
like the new Rachel and Hocamp duo in Goss, but and now in Texas. Hi, Dr. Langston. I saw your face.
Hello there.
So as we're getting started, we are recording. For those of you who are new to this set of rounds, you can already see by this amount of discussion that we are pretty informal here. We like to have fun. We've been doing kidney rounds this way. It's 2017, maybe 2016. We've been doing it for a while. So, obviously the group has changed, the group has grown, and but we still kind of keep the relaxed vibe around here. They are recorded, they are stored, and they are viewable through the ACVNU hosting site. And so any cases that you might want to look back upon, I think Summer was usually pretty good about putting just a small blurb about what the case was, but she hasn't asked me about for previous ones, so I'm not sure how recent she's been uploading them, but we'll have to check with Summer about as she's uploading them. Um, and then housekeeping, we invite people through the distribution list. If you have other people that you know that might want to attend, please email me or Dr. Hokamp or Dr. Nabity, and we will make sure that you get added to the list. We do know that Outlook randomly ejects people from the list for no random reason, but they also keep people on the list that have changed jobs multiple times. Uh, so if you have been invited and you're currently on the list, and then eventually a month or two goes by and you haven't gotten an invite, then something happened with Outlook. So again, reach out to us and we will re-add you to the list. It doesn't take much time. I just have to make sure I have it flagged on my email to do. Um, and there is no rhyme or reason for how it happens. Dr. Hokamp herself has been kicked off the list, and she is, based at Texas A&M. Always reach out. We always at least send an invite. We may not have rounds every single month, but we at least send an invite to see if there are cases that need to be discussed or should be discussed. So there will always be a request for cases email every single month. That being said, I cannot host, I will not be able to attend in May. So us pathologists are going to get together and see if we can find somebody else to drive rounds or maybe have more of a ClinPath based rounds or something. But there will still be a thing in May. It's just whether or not it probably wouldn't be directed by me. I'm Dr. Cianciolo. I'm Rachel. Um, okay, it does look like there's a lot of names on here that I don't recognize, so it does seem like there's some more people, which is why I was trying to give a little bit of a blurb. And then also, we have a lot of experts that are on these rounds. And so this is always a good time for us to, to poke their minds and dig in and see what they would do with that particular case. For the newbies that are on here that are maybe trainees or in residency programs, this is a great opportunity to interact with everybody. And nobody here usually has the magic answer at this point, but we're all trying to do our best to diagnose these cases and figure out the best treatment program or modality. And then lastly, if you have a case and you've submitted a case and you would like something to be discussed, it can be anything in the urinary system at this point. It can be kidney, it can be ureter, it can be urinary bladder, it can be urethra. I hope we don't do any repro associated with kidney stuff. But we can do any of those types of systems as you guys are submitting cases. If you're the clinician on the case, then if you get the report, say, hey, would this be a good case? We'll put you on the list. And then we already have a case chosen for the next month. So it helps us out a little bit. If you're a pathologist and you've seen a really cool case through your service and you want to present it or maybe just do a gee whiz, because usually I have like a little bit of time at the end of the cases, again, reach out and say, hey, can I just do a quick blurb or can you help me figure out this one particular case? And we can do a deep dive into it as well. So there's plenty of options for presenting, whether it's pathologist or clinician. And then as you'll see, people do put together PowerPoints. It's not necessary. It's just having some knowledge of your patient that you're talking about. I think people like to have PowerPoints because they're going to present from it anyway. It keeps the numbers easy and close at hand. So it's more than we're happy to have PowerPoints available. But if you don't have time to generate one, that's fine too. And we just need the clinical information that you might have in your background. Wow, we've got 25 people. That's actually a pretty good group. Usually we're around 18 to 20, so this seems like a good group. Anybody have any questions before we start with this case? Okay. I'm gonna turn off my camera and then like mute, unmute whenever I have pop-up questions. And anybody who wants to put something in the chat, that's great. Raise your hand. Also, again, it's very laid back, very relaxed in this group. So figure out ways you want to ask questions, and we can figure that make sure that the presenters know when to.
Uh-oh, where did that go? Oh, she stopped talking. Can y'all hear us okay?
Yeah, we're good.
Okay. When you stopped talking and I was like, oh God.
Yeah. So sorry, we were having technical difficulties, but thankfully my housemate over here is helping me out. So I saw this case last year. Her name was Sadie, was past tense. But she was really interesting from a couple of perspectives. So I'm going to give you some background on her. So 7-year-old female spayed golden retriever dog who originally presented to our ER service with the chief complaint of vaginal discharge. She had a history of a 5-month duration of vaginal discharge that was described as primarily bloody. She was intact at the beginning of all of this, and so they thought she had a PIO, so they spayed her at that point in time. But that discharge continued after being spayed. This progressed to straining to urinate and defecate, and then she became lethargic and anorexic, which is why she presented to ER. They had recently performed the referring vet at BRAF, which was negative, and they actually explored her in like a few weeks prior to her presentation here, and it was, quote, a negative XLAP. And then on physical exam here, she had a very thickened urethra, and that was really the only thing that was quite remarkable on her PE.
I'm going to ask a question to
Yeah.
the group, and this is not anything to do with science. How many people, if you guys can raise your hands, how many people say BRAF? And then the other option is going to be BRAF. So for everybody who says BRAF when they use this word, please raise your hand. In the thing. Oh, ask. Oh, just stop. It's a okay. I don't know if I can see everybody. Can I see anybody raising their hand?
I'm not seeing anybody raising their hand.
Okay, how many people say? Oh wait, the other option was
Oh,
B.
there's one. Okay. I got one hand up.
Okay, so we have B. That was BRAF,
Oh,
and then the other people say BRAF. Is that what I'm supposed to be saying this entire time?
Well, it depends on who you talk to. If you talk to,
I was saying it wrong for a while.
yeah, if you talk to some people, and people who invented the test primarily call it BRAF. For dogs, I should say. It was invented for people like way before then, but the group, Breen's Lab and the NC State folks who, further commercialized it, primarily say BRAF, although Breen himself will occasionally say BRAF. It's kind of funny. But certain oncologists are very opinionated on this. And so if you say BRAF, sometimes they make you feel dumb.
Okay, this is good to
I
know. Okay.
I
I
have
mean,
been,
it makes sense that, I mean, it's not like I ever worked on the research. I always just read it in a paper. And for
yeah,
me, BRAF would be B-RAF.
I know, and it's not like in the papers it gives you the pronunciation.
Okay, well, now we all sound a little bit smarter, and thank you for letting me interrupt. That makes me, okay, so from here on, I will say BRAF. It will be one extra syllable to make my talks even a little bit longer.
Yeah,
There you go.
but it's okay. At your speed, no one will know the difference. Um, so um, so she got an ultrasound with us, and the rest of her, it was a full abdomen, but I only put in here the urogenital component of what they saw in ultrasound. There was really very little that was remarkable about the rest of her abdomen. But just on ultrasound, and they knew I had told them that she had a thickened urethra. They saw this mass ultrasonographically. It really didn't show up very well in the images. It just looks like a blob, so I didn't put that there. Ironically, they didn't mention, like in urogenital, they didn't even mention her kidneys at all. I just took an image from their scan and put it in. I thought her kidneys lacked corticomedullary distinction, and I probably would have commented on them. And I mentioned this just because of things that will move forward with her case. So it was interesting that there was literally not a mention that she had kidneys. She did. She had two. And they looked like this. And then in her bladder, there was also a distinct little nodular thing in the body of the bladder. And it didn't look terribly interesting, but there was a mass there. And so at this point in time, we highly suspected urothelial carcinoma for this dog, given her signalment and what I felt. on exam. But she did have labs performed. She had a CBC chem and a UA. Oh, I got rid of those in here. Um,
I can pull them up.
yeah, so her CBC and her chemistry were really unremarkable. Her UA was not unremarkable. And so the lovely Dr. Hocamp next to me is going to pull those up. I can move ahead though, just for continuity. I did scope this dog, and these were some representative images from her cystoscopy. I say cystoscopy, I really should just say vestibuloscopy, because this is her vestibule, and her urethral papilla is sitting. I don't know if you can see my mouse or not,
We can.
but her papilla is under this one, I think. Um, and I was able to eventually kind of sneak my scope there, and I got a wire up into her bladder, and actually got a catheter in this dog to give her some relief because she was completely obstructed, which probably not surprising given that this is what her vestibule looked like. But I couldn't get a scope up her urethra, even the neonatal. I mean, it was just so infiltrated with mass. I went ahead and got biopsies of this. So those were pending, and we got her basic labs back, CBC Chem UA, and then I'll switch over to Dr. Hocamp. But again, CBC Chem, really nothing interesting at all. Even being obstructed, she wasn't obstructed for long. Her at was like 0.7 at that point. But her UA was interesting.
Here, okay, which one did I decide to do? I have two of these open. I had two of these. Are you seeing my screen that says Sadie?
Yes.
Okay, excellent. All right, so urinalysis, and I do have Dr. Boston on here. She was able to join. She was the resident who actually, hi, I can see you now. um, uh, who churned out all of these results for us. And so Taj, please feel free to jump in on any of this. But yeah, the urine was brown, decent specific gravity, but basically very, very bloody, and had what were described as dysmorphic red blood cells. Taj described them as biconcave with 1 to 2 vesicular protrusions, and she was kind enough to send me the images for these to point this out. First of all, that's a lot of blood. But importantly, these biconcave red blood cells that have these little protrusions, sometimes multiples, a little Mickey Mouse here, really large one there. Very unusual and very repeatable. And they are not isomorphic, so they're not matching what you would see in the blood smear. I'll go back to that in a second, but just to compare, here's the blood smear of this case. And there were rare acanthocytes and schistocytes, but not these blebbing vesicular protrusions. And then Dr. Boston also did, I'm assuming this was a cytocentrifuge of the urine. It's a little hazy, but what we can see is that you can still see the protrusions on a right Giemsa stained cytocentrifuge preparation. Dr. Boston, you want to say anything about these really cool cells?
I'm gonna say most importantly, they're so cute. But
They are so cute.
yeah, so I was very excited to see these. And humans, they have described these, and they're typically associated with glomerular disease. So upon seeing these, I wrote a nice long paragraph describing them, and also saying how in the human literature that they are associated with that. And I think we ended up recommending to also do a renal biopsy, just to exclude the present, or try to investigate to see if there was also a factor with the kidneys and not just that urethral mass. So,
well, and very I've got some images in here as well, just to demonstrate that concept. Here are some cases that we've had through the IVRPS that had confirmed glomerular damage on biopsy that also have the blebbing little nose things, sometimes, two of them. And then Dr. Nabedy and I and Dr. Boston, well, mostly Dr. Boston, you were really the one who delved into this, whatever, how you say it, performed scanning electron microscopy, and I pulled some of the coolest images here. So these are all scanning electron micrographs. This is not from this case. This is from dogs that had glomerular damage and had dysmorphic erythrocytes. So just as a quick example here, this little guy that has this little nubbin coming off, and here's his zoomed in version. And Dr. Cianciolo likes to draw a little face on him right there. And then we've got that lovely guy, and then here's another one with a little bleb and what looks like a gumdrop sitting on top of a red blood cell. There's a lot more of these, but these are some of the coolest ones that I pulled out. Again, just as examples of confirmed glomerular disease causing dysmorphic erythrocytes.
Do these have a specific name, like based on their shape in your ClinPath verbiage?
Dysmorphic erythrocytes would be the name. There are in human literature, they also use acanthocytes, which
that's what we like. That's what I'm used to hearing, and that's why. Yeah. Okay.
Yeah.
Yeah.
They will use that term, but it's kind of, we use that on blood smears.
Yeah, and when I did a lit search on this, there are several papers that talk about this and that go through. There is one nice imaging paper that compares humans to veterinary species with glomerular disease and dysmorphic red cells. They also call them acanthocytes. That is out of the Brazilian Veterinary Research Journal, and it has a different name in Brazil, but that is like the translated name. If you look up Brazilian veterinary research, dysmorphic red cells, you can find it. I had it in here, but then Hokim had like these beautiful images, so I took it out because these were better. But they do describe that in there, and there's some other references from humans that talk about these glomerular lesions and show the red cells going through the glomerulus, and you can actually see them like on EM, and you can actually see these like particles emerging from them, which is really, really cool. So I think, we actually have images of this happening in biopsies from people. I'm not aware of anyone actually seeing that in our species, but we assume it's the same process. Um, and and that is all I was able. We looked really hard because, and we'll see some other images from this dog, but I was looking for other reasons to have dysmorphic red cells. Now we have this really profound urine, and that was really repeatable, and they were everywhere. And then on her peripheral blood smear, there wasn't anything that looked like this. And I mean, she did have some acanthocytes in our classic term on red for red cell morphology on blood smear, but she really didn't have the same type or subtype of acanthocytes that we are describing in the urine.
Yeah, I guess I will say, so when I go to kidney rounds, that's the words sorry, at the med school, that's the word we use when we're talking about glomerulonephritis, and like Dr. Rowan will just be like, "Hey, did she have any acanthocytes in her urine?" So I guess as this discussion and the whole topic of red blood cell morphology and glomerular disease, and then obviously having these one-offs that's not going to be a glomerular disease case, but we're going to have to make sure that we use that word at some point during the paper so that we can say in human literature they're referred to as acanthocytes, but we prefer the term blah 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 to keep it a little more specific so that it'll be searchable whenever we want to do anything like that. But that's just the word, and that's why I was asking because that's the word I'm used to hearing in rounds.
Yeah, I mean, it does seem reasonable because they do describe the same types of cells that Taj found with the Mickey Mouse ears. Those were described as acanthocytes in the human literature, and they look just like that. So I do, yeah, we can talk about that, but I think we should probably at least include that term because it is, referenced like that in other papers, but that's neither here nor there at the moment. Um, but so this dog, she did go on to, so I scoped her. I did prep. I took her biopsies after I got biopsies and I put them on a slide and just did kind of impression smears. And this was, thank you, Jess, for pulling this up. So this was an impression smear from one of the biopsies. I'm not sure if I should keep
Yeah,
talking or
yeah.
let anybody else.
And again, Dr. Boston, you read this out, so if you want to jump in at any point, but basically we've got a very highly cellular sample that does have multiple spindled to sometimes round cells that display pretty marked atypia. And by atypia, I mean we've got anisocytosis and mesokaryosis, elongated nuclei, macrokaryocytes. Sorry, I'm like having a problem with that word. Um, uh, Multinucleation, binucleation,
Yeah.
nuclear molding. We also have neutrophilic inflammation in here, not entirely surprising. But these are neoplastic cells, and I think Dr. Boston, I think you called it just malignant neoplasia,
Mhm.
and then listed out some potential options, but basically, even though we would typically think about urothelial carcinoma, it does not cytologically look like what we think of as
Mhm.
a urothelial carcinoma. Um, any comments on the cytology, Taj?
Nope, yeah. I I didn't see the typical melamine Willinska bodies
Mm.
to say it was UCC, but yeah, so it didn't look typical.
And then we did also have peritoneal fluid from the dog. I don't know when that was submitted, but there was concern for uroabdomen.
Yeah, it was at the same time.
Okay.
So when we scoped her, her bladder she was transferred to us, and it was, everything takes longer than it should in academia. And then when I looked at her, we had done a POCUS, saw that she had effusion, and we aspirated her effusion, and that happened under the same anesthesia as the cystoscopy.
The fluid that we got, it was held for chemistry, and so it was cytology only on the peritoneal fluid, so it didn't have a complete analysis. So based on smear, it looked like a transudate with increased proportion of neutrophils, but again, a total cell count was not performed. But chemistries were performed on that, and the peritoneal fluid had a creatinine of 27.4, and potassium was very high, both very high compared to the serum. So,
Yeah.
And I have a quick question about that. So normally, I think about using creatinine to confirm a uroabdomen, but I know you guys have been submitting lately or maybe historically for a while now, both creatinine and potassium. Is there a reason to have both versus just creatinine? Just more confidence?
Clinically, I would say yes. We've had a couple of cases that had creatinines of their urine that was potentially like just a little bit higher and still pretty nebulous as far as is this consistent. And some of those potassiums have been substantially higher. And so we have historically done both of those for, I think, increased confidence is the best. Um, and why that is, yeah, I'm not sure, but we've definitely had cases where creatinine alone has not been a slam dunk and kind of gray zone. This one was not that way.
yeah.
Other clinicians that would submit peritoneal fluid, or do you guys have any guidelines that you would use? Or just
I might comment. This is Cal Gill. I have had the same experience. I think that the relationship between serum and peritoneal fluid potassium is more sensitive for for urine in the abdomen. That's been my observation for a long time. And occasionally, like in this dog, you would get a potassium concentration that wouldn't be consistent with life or certainly not normal cardiac health. And in the peritoneal fluid, creatinine just may not have been equilibrated or be as high as you would find it in the serum. So I would agree that I think it's a more sensitive predictor.
Cool, thanks.
Hopeful. Thank you. I think that's all I had for my part. If Dr. Dodson would like to talk about what we found on.
So she died.
Oh, yeah. Okay. So
Yeah.
maybe some additional clinical history
Yeah.
here.
I placed a temporary urethral stent. We got neoplasia back. The dog had a uroabdomen. The owners elected to euthanize, and we sent her to our anatomic path service for necropsy with this history, and concerns about, and then kidneys came here
Kidneys came up here.
Yes. So there's a lot of coordination between various labs, which I really appreciate. So thanks to everybody on this call who helped with this case. And is Haley on?
She is.
Yes, I'm
She has.
here.
She
Okay,
is
I need
live.
to I need to share. I think Jess, you're still.
Am I? Oh,
You're fine. Yes, so let me pull up. Give me a second. Uh, uh. Yes, and I'm sorry, I also couldn't get my camera to pull up, so you guys just have to look at an image of me with Stan the rhino from the North Carolina Zoo. Um, okay, share. Let's see if this get this to work. Okay, can you see the PowerPoint?
yes.
Okay.
It's in like your working mode. There it goes. Yeah.
Okay. Yeah, yeah. Okay, cool. So, yeah, so we got Sadie on autopsy. I was a resident at the time of this case, and we didn't include the biopsy results in here, but which was already kind of previously mentioned, there were some samples submitted from the vestibule of Sadie, and basically the concern was for a neoplasm. At the time, it was considered most likely to be urothelial cell carcinoma, so that's kind of what we were going off. So we did our gross examination. Most of the lesions were centered on the urinary tract, mainly the urethra, and the majority of the autopsy was pretty much unremarkable. Um, so these are some of the gross images we have. So here we could see we have the kidney, ureters, bladder, and then urethra extending out to the external genitalia, which is usually what we do when we want to take the entire um, urinary tract or urogenital tract when the animal is still intact. Grossly, before we actually dissected into the structures here, the ureters were slightly dilated, and then obviously it's diffusely congested. That we can see like the serosal surface of the bladder and the kidneys, and then this is down into the urethra. This is where the biopsy was taken, which was sent to the IVRPS, so that's why there's like a wedge piece missing out of the left kidney. So this was done post-mortem. This wasn't done while the animal was still alive.
It was kind of like soon after the animal was euthanized, right? We got
Yes, yeah, yeah. So that's what this like defect is here. This wasn't related to her clinical history or picture for this case.
And I will say, just for the clinicians listening on here, that is something that is a possibility. If you guys know that the animal is going to be euthanized and you still want to try to get your best chance for an answer, we do recommend kind of as soon as everything is comfortable for the owner post euthanasia, getting a couple of cubes of cortex. And it will be relevant for this case because um, we only got cortex on these samples. So when we wanted to look at the kidney, we went and we asked for more tissue from the autopsy sample and not from this biopsy sample. But doing a postmortem biopsy is one thing that we encourage if the freshness of the sample is very important.
Yes. And so what we could see kind of grossly here is so we come down to the neck of the bladder. The diameter of this looks more normal, and then obviously distal to this, it's very abnormal. We can see it's kind of bulging and widened and appears thickened. A lot of times when we get cases on the autopsy or necropsy floor, we'll try to express the bladder, the urinary bladder in situ. So before we remove anything to see if we can have expression, which we didn't appreciate in this case, we were not able to express urine out of the dog. And so then we did our dissection. So here's the urinary bladder opened up. The ureters and kidneys are gone in this case. And then this is the urethra down into the external genitalia we can see here. So this is towards the neck of the bladder, where the trigone would be, but we can see just distal to that, we have this very like exophytic, kind of pale tan white nodular mass that it would have extended into the lumen of the urethra, and it basically encompassed the entire section of the urethra. So it was a very large mass. And when we dissected and cut into the tissue, it actually looked like it encompassed every layer of the urethra, but that's hard to say grossly because sometimes if it's expanding like a certain layer, it can look like it's affecting all layers and it could just be a single layer. But grossly for us, that's what we saw here. Um, the bladder itself didn't ex seem extremely full when we had it on necropsy, so I don't know if it was decompressed. There was a little bit of like congestion and like a little bit of hemorrhage associated with the urinary bladder itself, but we didn't see like a discrete mass within the bladder other than towards like the neck and proximal urethra.
It was mentioned she had a urethral stent.
Hmm.
Was that still present at autopsy?
No, we did not see.
Did you guys pull it?
I
Or
think
was
they're
it not a
muted.
stent? Are you
It
muted?
was probably pulled
Okay, that's it.
right when she was euthanized. It was just a
Okay,
temporary stent. I think it was like
got it. Okay.
a silicone catheter. It was probably pulled right when we euthanized her, so it would have been keeping her bladder fairly decompressed up until that point. We cannot send animals for cremation with any of
Yep.
the material in them, so it's common practice as soon as they're euthanized, we pull all catheters. So that's
Okay.
probably what happened. I don't remember though.
That makes sense. And then one more quick question, Haley. When you guys were
Yes.
trying to express the bladder to see if there would be outflow through the urethra, you didn't notice any squirting into the abdomen, right?
No, no, we didn't see any evidence for a uroabdomen. There was slight autolysis, so it was a little hard to tell because the serosal surface of like most of the internal organs was a little bit red. But we didn't have like the smell of abdomen or of urine in the abdomen, or anything that would indicate that, and there wasn't any effusion
And I
either.
think that's a good lesson that the bladder has a really good way of sealing itself. So even if there had been like a little bit of tearing when the bladder was at its greatest distension. So right when she presented and she was really uncomfortable and her bladder was quite distended and it leaked a little bit, like the bladder can seal itself so well so that by the time she got the stent, everything was kind of contracted down and then you don't have continual leakage. Like as long as you don't rupture the bladder, I think you can leak a little bit of stuff into the abdomen, and then that's what you guys saw, a few days prior to the autopsy when she was clinically alive. And then by the time the animal was euthanized, um, the uroabdomen was no longer present because you had drained it, number one, and number two, she wasn't continually leaking urine into her bladder. Sorry, I'm just adding
Yes.
all these comments.
No, 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 it's good. And if anybody has like questions or anything as well, feel free to ask. We also checked for any evidence of like local or distant metastasis grossly. We didn't see anything. Obviously, it could be small, but at least grossly, we didn't see any other discrete large masses that could be associated with this or secondary to this anywhere within the body. Um, so yes. So then we did histology. So we took histology of through the mass in different sections within the urethra, and then also associated with the urinary bladder itself. So these were the gross findings. So at the time, based off just the gross results that we saw, and based off the history, we were like, oh, probably still like a urothelial cell carcinoma. We weren't really thinking of any other types of neoplasms, which obviously you can't always say definitively just off gross diagnosis. Obviously, you have things a little bit more rare, but still other neoplasms you should consider. So for histology, we're about to look at, so just put these together for us. So we have urinary bladder, and then there was also two sections. There was multiple sections, but these are two sections through the urethra with the mass included. So this is the mucosal surface. And then we're kind of extending down into the smooth muscle and the muscle layers. And then we have this very large, very multilobulated and densely cellular neoplasm. The cells themselves were very pleomorphic. The nuclear size and the cytoplasmic ratio was very large between different cells. They had multiple different shapes. Some were polygonal, some were kind of more spindloid or elongated. Um, there were a lot of cells that were multinucleated. So like these guys here, so this guy has three nuclei and very prominent nucleoli, very abundant amount of eosinophilic to basophilic cytoplasm. Um, Again, sometimes you could see they're kind of streaming, but a lot of times they were in like these very dense aggregates within the tumor itself. And then we also did have a little bit of like inflammatory cells, which is to be expected. So we saw some neutrophils, a lot of apoptotic cells throughout this neoplasm itself. Um, and so here's just kind of a closer up. So here's that kind of multinucleated cell with a very prominent nucleoli. Here's a neutrophil. Some of these are kind of more elongated or spindle shaped. This could be an eosinophil or a neutrophil here. But what was interesting about this tumor is that it did not extend from the uroepithelium or the mucosa, which we'd expect to see with like a urothelial cell carcinoma. This tumor seemed to be more associated with the muscle layers of the urethra and that kind of that distal urinary bladder. Um, so at that time, we were like, okay, so maybe this is not a urothelial cell carcinoma, which is what we were originally suspecting, and I think that's what we were suspecting off the biopsy. One thing we try to look for, and I have to go back and look again, is what we call strap cells, which you can see with like skeletal muscle tumors, which we looked for in this case, and I don't recall we saw any, but they're basically like immature muscle cells. They're elongated and they have this like striated appearance, which sometimes you can see with like rhabdomyosarcomas. But we weren't sure if this could be a smooth muscle or skeletal muscle, so we had to perform immunohistochemistry in this case to kind of differentiate the type of tumor that this could be. Again, this is not what we were expecting grossly. We were thinking probably just urothelial cell carcinoma, and this is again just showing how pleomorphic the cells were. Some of these cells were huge, again multinucleated, some were much smaller. So a very kind of aggressive looking tumor. And so, yes, and so here we can see some of these are kind of more elongated and kind of wispy. So for our immunohistochemistry, so some considerations that we have to give in this case were where are the cells originating from. So typically with like urothelial cell carcinoma, we do like a uroplankton 3, and I think you can also do a cytokeratin with that as well. If you suspect the tumors to be originating from like the uroepithelium, which we didn't see in this case, so we didn't perform a uroplankton for this dog. Other considerations were if this was skeletal muscles, so we could do a MyoD or myogenin, which is like transcription factors. So we'd expect nuclear labeling, which we did do a MyoD in this case. We don't have myogenin here at our university. If we think it's more smooth muscle, just like what's in the name, smooth muscle actin is a consideration you could do. And then Desmond as well. Desmond you can use in combination with other tumors. Desmond more specifically labels for skeletal and cardiac, but there are papers where it can stain for smooth muscle tumors as well. So I think that's something to have consideration for. So for our case, we did a Desmond and we did MyoD. We were thinking more likely this was skeletal muscle, but we wanted to check and see. So for our Desmond, so this was the urethra with the tumor, and then this was the urinary bladder here. We had, so Desmond should normally be a cytoplasmic stain, which is what we were seeing in this case. It was like about 20% of the tumor had cytoplasmic labeling, positive labeling for Desmond. And then those cells that were highlighting with the Desmond IHC, they were pretty much positive. But what was interesting is you can kind of see here, this is a binucleated cell. Some of these larger, more aggressive looking cells didn't label with Desmond. So then we also did a MyoD, which was to check to see if this was skeletal origin for this tumor. Again, so here's the urinary bladder. This was the urethral mass. So MyoD is a transcription factor. So we should typically see nuclear labeling. And in this case, what we actually saw mostly was a lot of cytoplasmic labeling, which was pretty much diffusely positive, and then there was scattered nuclear labeling for this case. So that's something to take into consideration where, we were like, okay, this is probably rhabdomyosarcoma. There are papers that do talk about where you have this more cytoplasmic staining. Could this be kind of more of a precursor to the myogenic cells themselves? So we could still consider cytoplasmic labeling with a positive rhabdomyosarcoma. But in combination with the fact that we did see cytoplasmic labeling with the desmin, we did in this case call this a rhabdomyosarcoma. We did not do a smooth muscle actin to assess for smooth muscle origin, and we didn't do a uroplakin 3 either to assess for urothelial origin or urothelial cell carcinoma in this case. What was interesting is that also this is a middle-aged dog. It's a 7-year-old dog, which usually you see botryoid rhabdomyosarcomas generally in a little bit of a younger dog, but not to say that can't be the case here. Um, as well as for the smooth muscle actin, a tumor we'd want to be excluding or including would be like a leiomyoma or leiomyosarcoma, so a neoplasm of the smooth muscle, which I don't believe we should see a positive desmin in that case, which we have here. But that's still something to consider in the future if we want to further classify. We could do more aminos for this case, but we did call this a rhabdomyosarcoma um, of the urethra for this dog.
Okay, sorry. And we were having a long conversation on the text on
Oh,
the
sorry.
yeah, oh
I
no, on
don't.
the chat. It was I just wanted to see what the biopsy that Jenna had taken at the same time she did the cytology, what the report for that was. And so it does in the chat that there was definitely inflammation at the urethra, and then there were intralesional pleomorphic cells. And you're right, like it isn't touching the mucosa, right? So it
Mhm.
doesn't seem to be urothelial predominant, and so they only saw a few of these atypical cells in the biopsy. It says with intralesional pleomorphic cells, and they suspected to be urothelial carcinoma just because of commonality of what happens in this location. But it probably they did not get the depth that you got to get the whole sheets of these cells to say, hey, this is probably not UC. So this is
Yeah.
really cool. Actually, I was going along the whole thing that the whole time I knew why I was looking at the kidney. I was looking at the kidney to see if there's glomerular changes because of the dysmorphic red blood cells. But I don't think I got the whole history that this was probably muscle within the urethra that had the neoplasm. So.
Yeah. Yeah. It was a very odd case. Not what we were expecting.
Yeah, and
Um,
I said I would have called this a rhabdo, especially based on the morphology. I mean, yeah, smooth muscle could but they don't get this atypical.
mhm.
Um, so, and we do have some other pathologists, especially the ones that work with the IVRPS, that also said this was. And I'm glad you guys did um the immunohistochemistry. If you guys are at some point going to want to do this as a case report for publication, I would probably just do a uroplakin 3 just to show that it's negative.
Yeah, definitely.
Um, and but if you can go back to that histology where you see the urothelium at the top, and then you can see the neoplasm at the bottom, just to highlight to our clinicians. So this is urethra, right?
Yes, correct.
Okay. Um, so when we're talking about how you guys get cystoscopy biopsy samples, um, uh the you guys are capturing, and I don't know if you can use your arrow to show what they would capture with their spot. So they're getting urothelium. You're basically
Yeah.
getting a glancing blow off the urothelium. You might get lamina propria.
Mhm.
The smooth muscle is a little bit deeper in this area, and so that and when we're looking for invasion, especially when we're talking about urinary bladder, because muscle invasive bladder carcinoma is, a big qualifier. When it comes to urethra, we think it's probably also important if it's invading the muscle, but we don't have those same grading schemes like we have when we're talking about urothelial carcinoma of the bladder. Like in the bladder, it's like one of the main criteria between high and low grade, but in the urethra, it's not as clear cut what the grading scheme should be. And Haley is the one working with Christina's on here as well, right? And we are tasked with figuring out what we're gonna use as our grading scheme criteria in the future. Um, this case is not urothelial carcinoma, so everything is deep. But remember, like as stuff is going through and it's coming out from the bladder's obviously been distended, it's really blocked, and things are trying to get through that urethra. That lumen of the urethra is still probably quite narrow, and there's probably all these little like folds and stuff on the surface that are going to be traumatizing the material as it comes out. Also, I guess I'm just having another thought though. Is there a possibility that just sitting in urine for a long period of time, no, that doesn't change red blood cell morphology? I mean, because we're going back to the fact that we're looking at this case because we had these
Yeah.
dysmorphic red blood cells in the urine. We had these acanthocytes in the urine. Sorry, that's my dog scratching at her neck. Kinley, can you please be quiet?
Which,
Okay.
and we haven't readdressed or gone back to address what we found on the kidney with,
Yes, I have those pulled up.
oh, okay,
Yeah,
got it.
and
Well,
Taj
which,
actually did an experiment.
Uh-huh.
If you want to say what you did, Taj, about the sitting in urine for a bit.
Yes, so I was able to try to get some normal, well, not normal, but hematoric samples that had isomorphic red blood cells initially, to see, oh, those was oh, sorry, that was to see what they looked like on SEM. But I actually was able to spike some urine samples with normal blood, normal looking blood, and to see what that would look like if the blood was sitting in the urine over time. Also, we did heat the samples to see if that will also change it. And we did have some weird morphology changes, but they were not the true like dysmorphic vesicular protrusions that we seen with the glomerular disease animals. So shouldn't have those changes with that.
Interesting. Okay, so I can show, I mean, so what we got from the kidney, so this was all presented to me as, hey, this dog has a urethral tumor. It's going for your autopsy. We're going to grab some postmortem samples so that you guys can look at them to see if maybe there's glomerular disease because of these dysmorphic red blood cells. Again, we're going with that theme that in human medicine, when you see dysmorphic red blood cells in the urine, you probably have glomerular disease and you probably have a glomerulonephritis. Like it's probably like a bad glomerular disease, not just, regular, like amyloid or whatever. So I mean that's also bad. But anyway, so it's usually like kind of one of those hints that they look for clinically. So we got just cortex, and I think I can share. Let's see what I'm at. What am I going to share? I'm going to share this one. Actually, what I'm sh that one. Sharing now is actually the deeper section. So let me go back to what we got first. Nope, that's wrong. So we got just cortex. And when we're talking about glomerular hematuria, it means that the red blood cells are coming from the glomerular capillaries, crossing the GBM, crossing that entire capillary wall, and ending up in Bowman space, and then following out all the way through the long length of the nephron to come out to the ureter, then to go to the urinary bladder. So glomerular hematuria, we would expect to see evidence of hemorrhage within Bowman's capsule, and we would expect to see abnormalities of the glomerular base membrane. So I'm starting with the Jones just to kind of iterate that these GBMs actually look really good. It's not so when we're comparing the Jones stain, we want to look at the thickness of the capillary walls. So here's our capillary wall. This one's even a little bit better stained. So that's a good capillary wall. This little nucleus here is a podocyte nucleus. And so we want to compare this GBM to the TBM of a healthy tubule. So we want to say, is this narrower or the same thickness? And if it is, it's normal. And we do that, it's not like I go through and like score 100 of them, but you can get a good idea that even with this early situation that you've got pretty normally thickened, or not normally thickened, the GBM is of normal thickness. You don't have a lot of double conjuration. You don't have any spikes. So all of those features that we would be concerned about are not here. And then plus, cannoli, really, honestly, are you guys hearing that? Can you hear it? No? Okay, then that's fine. I'll just keep talking through it. She's under my desk. Um, so we don't have a lot of red blood cells that are pouring into Bowman space either, so that's a little bit more helpful. Let's see what's my next one. Um, Hold on, it's because it's doing this. It's not letting me. So then so all like I said before, all we had was the what's the word? Oh, all we had was cortex. We didn't have any medulla. We have like a little bit, maybe a fibrosis over here. So let's see if that looks like on the trichrome. It's a tiny scar, a tiny region of scarring. So yes, this kidney is not 100% healthy, but this little tiny area can't be making all of those acanthocytes, and also we still don't see any like red blood cells pouring into Bowman's space. That is just kind of a chronic 12-year-old dog, gonna have some radiating scar tissue, and a little bit of glomerulosclerosis. But in general, the rest of the kidney looks great. We did get a deeper, so I asked to get more tissue so that we could look at from the autopsy sample all the way through to the renal papilla. And so when we ask our lab to do that, we really do want to see what's going on down here. There's a little bit of inflammation, a little bit of papillary hyperplasia of the urothelium of the renal papilla, pretty mild. This is all pretty standard for what we see in normal, older dogs. I'm not seeing a lot of red cell casts. So if we're thinking of glomerular hematuria, like going through the glomerulus, and I said as it goes through the tubules, it's probably going to get caught at some point, and then we're going to have casts within the distal portions of the nephron, and I'm not seeing that either. So I can't tell you where those dysmorphic red blood cells came from. What was the kind of the percentage that you guys had for number in the urine sediment? Was it like almost a lot of them were dysmorphic, or were they
It
rare?
It
was,
was,
it was actually
there were
almost
many.
a lot. Yeah.
Yeah.
Very
When she was
many. Yeah.
clinically alive.
When she was clinically ill.
Yeah,
So,
but there were a lot of them.
there are a lot. So so it ends up being like something was traumatizing red blood cells as they were going through and coming out of the body.
Yeah.
Um, and I don't know what it is. But we can say that the glomeruli themselves do not have evidence of an underlying like an underlying glomerular disease that was also contributing to it. We don't have red cell cast. We don't have hemorrhage or crust or any kind of things into Bowman's capsule. When we look at the trichrome, or when we look at the Jones, it looks like a normal GBM. I do want to use this opportunity to emphasize to you guys, this is an autopsy glomerulus. So this is one where I'm assuming the autopsy was a little bit later because you said there was some autolysis, right? So this is what an autopsy H&E glomerulus looks like. And let me find the H&E from the biopsy. This is H&E on biopsy. Look at the difference. It's a little, okay, that's just a bad scan. That's okay, but look at how different they look because of the sitting around stuff just kind of blebs into Bowman's face, and your glomerulus itself just gets a little bit more like it loses a lot of the red cells that were in circulation. And so everything just kind of accumulates in Bowman's space. There's quite a few. There are a couple polys I'm picking up here, but yeah. So just be aware that that's why we recommend these post-mortem as soon as everybody's comfortable with the fact that you're going to get a post-mortem biopsy. Like get it, because we're going to have the best opportunity to evaluate it. If you had tried to do a Jones on this guy, it would have been really hard to like to say what was going on. So I guess this does, even though we can't figure out what's going on specifically in this case, we had a lot of learning points from this case about sample harvest, and having an unusual diagnosis in the end. These are all just sloughed parietal epithelial cells that were, or maybe even some of them were podocytes. Sometimes also the tubule, as it gets squished, will push its epithelial cells up into Bowman's space. We often call this regurg. That's what a pathologist is talking about, tubular regurg. It's an autolytic fact. So this is much harder for a pathologist to read through than our gorgeous immediately postmortem well perfused sample. Um, so I'm sorry I can't give you guys an answer.
Well, I've been looking in the literature. I think Jenna's been looking. I'm sure Taj did. I can't find anything with lower urinary tract masses causing dysmorphic erythrocytes in the urine. Dr. Lee's put a message on the chat. He jumped off of the meeting, but he said there's things to know about looking for dysmorphic red blood cells in the urine of Alport dogs based on what physicians see.
Which that makes sense though, because it's glomerular. It's a glomerular
Yeah.
disease.
But I don't know. Do any clinicians, I mean, has anybody seen anything like this where
Are we just looking too closely and most of this would have been ignored by other pathologists that don't pay attention to urine the way Texas A&M pays attention to urine? Is it possibly that?
I do not think that most lab techs are going to comment or know about dysmorphic red cells. Even in the human field, nephrologists do not trust the lab techs to
You are
identify them.
completely correct. They want to look at the urine themselves. That's a
Yeah.
good point, Mary. Like literally, they don't believe what the lab says, so they go back and look at the urine themselves.
Cast and dysmorphic red cells, the two things they don't trust.
Yeah, I feel like the only other thing I could possibly think of is if, I mean, there's bleeding somewhere and it probably was associated with that mass. And if there was some type of like vasculature there that the red blood cells were squeezing through, that they were, I'm
That's
unsure, but it had to be associated with the mass in some form, probably, with how many that were there. Um,
I think this will be good. I know that you said you got the SEM for a reason, that you were doing this also. I mean, thank you for showing those beautiful pictures. Nobody's allowed to share this because it's going up. We're going to get it in a publication form.
Taj is
Um,
working on it.
huh?
Taj is working on it.
Gosh, it's working. Okay. So they're gorgeous pictures. Like it is really neat to have that access to be able to do all these additional diagnostics. And so but like let's just start looking at more urines when we're looking at these like obstructed bladders or these, I mean, it was obstructed. I'm not saying it wasn't obstructed, but like it would be really cool to have other triggers for like what we think the diagnosis could be. Obviously what the paper would be, and Dr. Vaden is raising her hand, so I will let her speak, but the paper would be more about the glomerular focus about when we see this in glomerular disease. Hi, Dr. Vaden.
Hey, sorry. I just wanted to step back a minute about the nomenclature for bladder tumors. So Mike Nolan and I went on this like pet peeve. And so I'm going to quote what we wrote to people at NC State trying to get people to use the terms correctly. In that urothelial cell carcinoma is kind of the best term. And we feel like the urothelial cell carcinoma has come out of a bastardization of those two. And that it's really like it has been used in publications, but when you look at the numbers, these are from Mike Nolan. There's 647 publications that have it that's been started since 1985, but there's almost 14,000 that use the term urothelial carcinoma. And that if you compare it to other tumor types, like you wouldn't say epithelial cell carcinoma or you wouldn't say endothelial cell carcinoma. And so our quest is to try to get people to use urothelial carcinoma instead of the term urothelial cell carcinoma. So it has nothing to do with the red cells, but just kind of folding back. What a perfect group to bring up this quest with.
And I think that's good because I think when I knew it was supposed to not be transitional cell, I knew that. And so I think I was misusing it for a couple of years. And then I went back to say, okay, I think it's just supposed to be UC and not UCC.
Right.
So that's
I
going to
think
be, good for that. And Dr.
well,
Calgill also has his hand open. Mhm.
yeah, for
Yeah,
those who
well,
were at Lower Urinary Tract Symposium, none of the speakers used the term urothelial cell carcinoma.
Correct.
I had a similar question, but on a different topic. And over the last few years, I've noticed the progressive increased usage of the term autopsy instead of necropsy when we're talking about animal postmortem examinations. And is that a trend, or is that both with some clinicians and with a variety of pathologists?
So I can speak to that a little bit. So it's been for the past 20 years. It's been since when I was in residency. Oftentimes people said necropsy, and there's still some people that will only say necropsy and will not say autopsy. If you look at the derivation of the word autopsy, it means to see with one's own eyes. It does not mean an examination of one's own species. So everybody thought the auto means one species, but it actually means to see with one's own eyes. So there's nothing incorrect about saying autopsy. It actually is a fitting word for that. There has been a transition from a lot of pathologists to say autopsy because owners understand that word. And if you're offering an autopsy to an owner, you don't have to say, would you like a necropsy? What will happen is we'll cut into the body of your animal. So I think that there has been, from a pathology standpoint, to say autopsy. There's still some holdovers, like a lot of lab animal medicine will not say autopsy. They will require necropsy in their SOPs. So in the pathology field, it's still kind of put down that way. I think Penn, Haley, did you guys kind of switch over to autopsy as well? If you're still on?
She says yes, same reasoning.
I
Yeah,
think that one was there.
That's a great
What
explanation because I think some of us older people have been trained, to the old explanation that was out there, and this is really great to hear that there's a more definitive explanation.
yeah, I was gonna agree with what Rachel said. Here at A&M in our residency, probably in the last few years, we were just asked to start using autopsy instead of necropsy for more for clients. And it seems like there's a better outcome with clients understanding.
I like
This is
how Shelley said it went back to necropsy, but it was Dr. Mutin was the one that was the first argumenter for autopsy. Like you guys were the first pusher for autopsy.
I can't. All I know is we were sitting in hospital board, and the discussion was, please let's start using autopsy again, and not, or start using necropsy again, and not autopsy.
Okay.
It was like, oh, I just
I mean,
got
this
this
was a
now.
call-in situation, and I just remember from that. So, okay, well,
Yeah.
we tried. We tried. Okay, so we are right at two. I do have a fun case that we'll probably have on hold for a future set of rounds. And the pathologist will get together and decide how we'll host rounds in May. I think I'm traveling that day. So it would be hard for me to attend. And if I can't see you guys in May, I will see you guys in June. And please keep in touch and let us know if you have any other cases to discuss. Thanks. And thank you guys, Texas A&M, for putting all this together. You guys took it over and did everything. It was great.
That was Ho Camp.
And she has another talk this afternoon. If anybody is interested, we're going to learn about breed disposition for renal disease through the AKC CHF.
Wait, I don't know how that's on my calendar.
It's not, I think I mean, if you want to come.
CHF stuff.
It's mostly for breeders, but it'll be fun. I mean, I think it'll help us like recruit cases.
It'll be fun watching Hocamp bumble over stuff.
I will be there to help for when you have questions. So, okay. Thank you guys so much. I really appreciate it. And Tosh, that was amazing. And we want to keep putting blood in urine and see what happens. Let's do it.
Let's put blood in urine. I love it.
Okay. Do you have a Zoom for that for this afternoon?
It's through CHF. It's not through
Yeah,
that. I mean,
I can forward to you.
Yeah.
Okay.
sounds good, guys. Thanks so much. Appreciate it.
Bye.